So, Ms. Morris, you're gonna lead us off for the QA.
Yep, we've had some great questions in the Q&A box, and still time to add more if anybody has questions for us. So the first question we have is around peritoneal dialysis. Practically speaking, USPD patients generally have to come in for monthly labs, IV iron, etc. Regardless of the legislative ability to do telehealth 2 out of 3 months under the Chronic Act, how do the Canadian PD programs use telehealth and that need for lab draws and IV medication?
Yeah, thanks. So luckily, we have access to local labs. So patients can go to a local lab close to their home and have the labs drawn. They don't necessarily have to come to the clinic to have the labs drawn. So that's one way around it. Another way, the issue around IV iron and visits for other reasons is certainly a challenge, but we do our best to try to work out the in-person clinic visits around the need for IV iron. So yeah, obviously we're not saying that they're going to completely replace all in-person activities, but can they minimize it? I also know this is going to come as a real shock to everybody, but we see our patients once every 2 months who are stable, not once a month. And I think that that's something that we definitely need to study because our patients are busy and leading very busy lives and working. And so we have not seen any, adverse outcomes with once every 2-month clinic visits. And there was a paper published in AJKD last year or 2 years ago, led by a group, Dr. Wald and Dr. Allison Thomas, a nurse practitioner, looking at every 6-week hemodialysis blood work versus every monthly hemodialysis blood work. And there was no real adverse effects to having blood work every 6 weeks versus every month. So maybe in a similar vein, we can study the issue of the frequency of blood work and clinic visits in patients on home dialysis and outcomes in an effort to reduce burden.
Great. We have a transplant question, I think, to follow up. Can you address steroid-free protocols and their success rates?
Absolutely. So steroid-free protocol is something that we all tried to adapt for a while. And what we found is 3 big overarching messages. One, if you want to do a steroid-free protocol, you want to be steroid-free from the beginning. If you are on steroids and try to withdraw them later, the risk of rejection is very high. 2, in the steroid-free protocols, the fundamental driver for it was to reduce metabolic complications because of steroids getting the bad rap of the Cushing syndrome. However, as the dose of steroids being minimized to initial maintenance of 10 milligrams and eventually 7.5 or 5, depending on what the immunologic risk is, what we're finding is that many of these metabolic complications we can manage, but when you don't use the steroids, you're depending on higher doses of tacrolimus and mycophenolate, and they have side effects that go along with them. So it's a trade-off there. Many centers who started off as steroid-free have sort of gone back to being steroid-dependent. And in the US, 90% of the programs are using a 3-drug maintenance immunosuppression at the present time. So,
thank you. How is the recruitment of the peer mentors handled?
That's a great question. Since I've been a 29-year patient advocate, myself and one of the other advocates, Aaron Battle, who we have been trained together in, and we have both worked at iPro ESRD Network 2 for many years. We've received and we've trained plenty of peer mentors. So we pretty much do a lot of the recruiting, and we've developed our own training modules along with other resources that we've gathered from the kidney community to train our peer mentors. So we use a lot of personal experience and some great resources that we've developed ourselves to train our peer mentors.
Intrigued with concept of starting PD pre-ESRD as a way to extend time before the need for routine dialysis. What kind of experience is there?
Yes, so I'm just going just look at that question a little bit more. I think I don't think that there's a role to start PD earlier. Because, PD preserves residual kidney function, people have thought that maybe if we start earlier, we will impact the decline in residual kidney function because it's a protective therapy. But the ideal study, the initiation of dialysis early versus late, was a study published, a randomized trial of in Australia, New Zealand, and Asia Pacific, did not show that randomizing patients to early start dialysis had a benefit. So I think now the guidelines would suggest that we start dialysis, typically around EGFRs of 5 to 7 mils a minute when symptoms develop, and or when there's challenges with volume and potassium, but there's no benefit to starting dialysis early. I will say that there's been 2 studies that have looked at the slope of decline before starting dialysis in kidney and the slope of decline after. And it seems that when patients start PD, the decline in kidney function is a little bit slower. So maybe there is something protective around residual kidney function decline in PD. There's been 1 study from Australia and 1 from Toronto, but I would advocate that we should be starting patients earlier. I always say plan early, start late. And to Dr. Kumar's talk, that also means really educating about kidney donation among family and loved ones, and transplant preparations, as well as optimal dialysis start.
And I think that's right. And as you say, Dr. Perl, we don't really know why it is that patients lose residual function. But I think that the data is true in all forms of kidney replacement therapy, that earlier therapy not only doesn't produce better outcomes, but doesn't benefit patients substantially. So I think that that's universally true at this point. Yeah.
For living related preemptive transplants, that's also a slippery slope. There's so much preparation and so much organization that goes into it. You also want to make sure that you don't miss an opportunity, but at the same time try to start right on the cusp of not having symptoms and feeling unwell. I find that really challenging as a nephrologist to try to work out.
I have 2 questions about CMV, so I'm going to sort of squish them together. And please excuse my pronunciation.
You're good.
What is the status of porcine CMV and endogenous retrovirus in xenotransplantation? And then the second question is, pig CMV was thought to be related to why heart xenotransplantations died, despite the fact it was genetically engineered, and what work is being done on this obstacle?
Thank you, Dan. Brilliant. Both questions are brilliant. And so I'll answer them in 3 key points again. 1, getting the donor pigs, keeping them behind the barrier until the time that you're ready to get the organs from them is key. That's number 1. So all these pathogen-free facilities have to be created. We have a pathogen-free facility in our area away from UAB where we keep our pigs behind the barrier. Number 2, prior to taking the organs, you want to check the pigs for porcine CMV. That now currently is only done through a PCR technology. That was done for both the hearts and for us. The thing that was missing that we've now developed is actually getting a donor serologic testing. So if you look at CMV in human to human, we are able to check a donor for CMV IgG or IgM. And so we know if the donor has been exposed, because what can happen after transplant is reactivate sort of transmission of the porcine CMV into the recipient. And PCR can be negative. It just tells you there's nothing detectable in the moment in the blood. But what if that pig has been exposed, has cleared it? And as we know with viruses, they can stay in sort of a have tropism and stay dormant until immunosuppression is introduced. So we are now have developed a porcine serologic test, so we can test this pig donors not just for active PCR, but actually prior exposure. So if they're behind the barrier, PCR is negative, and there's porcine IgG is negative, then that becomes the more ideal scenario. And when we first move to clinical trials, that's what we need to do, along with finding antiviral therapies that'll actually preferentially treat these porcine CMVs, because the human antiviral drugs don't seem to be as effective.
Thank you.
Thank
and
you,
Dawn,
Dr. Kumar.
oh, sorry. Dawn, I have two questions for you too. And again, I'm going to squish them together. Does the wellness ambassador also provide support outside the center, that is house visits for patients who trial home dialysis or nocturnal sessions? And the other question is, do mentors only go to the dialysis clinics or do they go into hospital settings as well?
Those are both great questions. We haven't started visiting hospitals, and nor do we go to the patient's homes. However, if a patient would like to speak to us in a home or a hospital setting, we can set up a virtual visit via Zoom, and we can speak to a patient from literally anywhere, obviously, or we can do a telephone visit with a patient if they don't have the Wi-Fi or the internet access. But basically, the in-person visits take place in the dialysis facility setting.
Again, I think I'm going to squish these two questions together. At what stage are you a candidate for PD versus HD at stage of ESRD? In other words, if you are stage 4, are you a candidate for PD or do you have to start HD at that stage? And the other half of the question is, how are we providing support and education more upstream to our patients, i.e. CKD 1, 2, 3?
Yeah, so a couple things. I don't think that the stage really factors into candidacy for home dialysis. I think that typically, as we talked about, there's no benefit to starting early. So we look at things like the kidney function risk estimating equation, which really helps us prognosticate somebody's need for kidney replacement therapy. And when the KFRE, is about 80% risk at 2 years, we really start to intensify our planning for transplantation options and kidney replacement therapy. And I think at that point, patients should be educated about their treatment options, and it really should be shared decision-making, looking at, individual, what are some of the concerns or not for different therapies. And I don't think that patients have to start hemodialysis to transition to PD. In fact, I think that sometimes is a symptom of a system that, in many ways could have perhaps prevented an urgent start on hemodialysis and provided education so patients could have started optimally on whatever therapy they choose. So I think that that's, so how I would answer the first part. The second part of the question, I would say, I must say, I think at CKD 1, 2, 3, it's a little bit early to get into the real detail-oriented education. I think that at that point, it may actually be counterproductive because it may be too much information. And so I think at each stage, we have to think about, stage-specific things to talk about in education. And I think at stage 1, 2, and 3, the focus should be on prevention and, at all stages, introducing principles of self-management and education. But I might not necessarily at those early stages focus as much on kidney replacement therapy planning as much as prevention and, cardiovascular risk factor modification, mental health and well-being, those sorts of things that I think might be more relevant at those stages.
And I agree completely with what you're saying in terms of that. Hemodialysis is often a last resort, and for a patient who's inadequately prepared, as you say, they end up with urgent start dialysis through hemodialysis through a catheter, whereas patients who are better prepared end up with either home dialysis or preemptive kidney transplant. And I agree with you that early stages of CKD, the focus is on prevention and education, much like Ms. Edwards talked about, right? It's educating particularly high-risk communities about the risk factors for kidney disease and how they can prevent and control those risk factors.
Yeah. One of my favorite studies is, Dawn, I don't know if you know of it, is the barbershop blood pressure intervention, which I just found fascinating.
Yeah, I think that's great as well. Yeah.
Cool. Dawn, I have another question for you. In your time and work, are you seeing a change or shift in trust of healthcare professionals among our Black community? Our experience are rooted in trauma, and trust is everything for our community and people.
That's such a great question. I think with all of the information, the health information that's flooding our airwaves and the barber shops and the beauty parlors and, meeting people where they are talking about healthcare, it might be slightly moving the needle a little bit. I just think much more health and awareness information needs to be in those communities so that people can really get a sense of how important early detection prevention is. These are the things that are so near and dear to me to talk to people about, hypertension and diabetes and taking care of those things in those earlier stages. Uh, I'm hopeful that with all of the health information and all of the health equity work that's being done in those communities, the underserved communities, now we will be able to move the needle a little bit further and to be able to help people to take healthcare a little bit more seriously than we have been in the past.
Jeff, I have two more questions if we have time for that. The first one is there a patient ick factor or other psychological barriers to receiving a pig transplant?
A patient X factor or psychologic barriers?
Yeah, ick, I
So-
think, like a, ooh, that's
Oh, yeah,
ooh,
yeah,
not
yeah.
so
No,
nice.
I think these are such important questions. The first patients who are going to be part of this, it's going to be part of the clinical trial. They're going to be pioneers. So really sitting down with patients who come forward who want to be part of these trials and asking them what is it they understand, what are their fears, what are their concerns, what do they expect is going to be the outcome, and really answering those questions, not sort of throwing information at it, but really pausing, waiting, inviting questions, understanding where they are. That's a huge area of need and work, and there's active work happening in it through multiple societies, both NKF, ASN, ASD, other patient organizations. In the South, there's definitely an ick factor, right? If you think about, are people going to look at me as a pig? If I have a pig organ in me, that's a real thing. Some patients have said that. So we'll be looking to our initial pioneer patients, one or two, to address these things, and they will then become our spokesperson for the future things. I just try to remind myself, because I get impatient when I think about all these patients waiting and I wanted an intervention yesterday to work. I have to remind myself that the first kidney transplant happened in 1954, and it was decades before transplant became what it is today. And progress is happening, maybe not at a pace we want to, but we keep the faith and we keep going and we'll get there.
And Dr. Kumar, I think what you bring up is a really important point. Patients are frequently nervous that, they're going to be looked at differently. And Ms. Edwards, I know that's something that you deal with a lot in your role as a wellness ambassador. How would you address a patient who was worried about what Dr. Kumar just spoke about, or other visible signs of their kidney disease, be it a hemodialysis access or a peritoneal dialysis catheter?
Mm-hmm.
Yeah, we just try to support patients with factual information. I mean, the most important thing is to get your quality of life back, to get your wings back, to feel better. And when you provide a patient with actual factual information, and sometimes you show them someone that looks like them that's gone through that similar experience, it makes a huge difference. I thought it was so funny with Dr. Kumar when she said that people probably wouldn't want to accept a xenotransplant because they think they'll be a pig. I have actually heard patients that say, I wouldn't take a pig kidney because I'm not going to want to eat bacon anymore. I mean, these are actual myths that are flooding, our community. These are things that we hear in the waiting room. And we as wellness ambassadors and advocates, we have to go in and we have to debunk these myths and reprogram patients, to make them understand that, we're trying to get you healthy and well and get your lives back. So it's a real challenge, out there to feed patients real information, real-time information, and factual information that's going to help them make those informed decisions to help them get their wings back.
Thank you. And I think that's a great way to end, is the goal is to help patients get their wings back. Unfortunately, we're 15 minutes over time, and I know there's still some outstanding questions, but I'd like to thank everybody for their participation today. I'd like to thank you all for joining us. I'd like to thank Rogosin's development team and IT team and the IT team at NYP for helping us put this on. I'd like to thank Dr. Kumar, Dr. Perl, and Ms. Edwards for their time in joining us and putting together their presentations, which were absolutely wonderful and terrific. I think that this has been a great symposium, and I thank you all for joining us.
Thank you for having us.
Thank you.
It was a delightful time. Bye, everybody.
Bye-bye.